Welcome everyone to our seminar today, Putting HPV Vaccination Data to Work. Our seminar is organized by the American Cancer Society, National HPV Vaccination Roundtable, Indiana Immunization Coalition, and St. Jude Children's Research Hospital. I'm Heather Brandt, and I'll serve as the moderator today of our seminar, which is the first of 3 focused on improving HPV vaccination coverage. I am moderating the first session with subsequent sessions moderated by Jen Conga with the American Cancer Society and Dr. Gabby Darville-Sanders with the National HPV Vaccination Roundtable. Additional members of our planning committee include Katie Crawford with the American Cancer Society and Duha Magzub with the St. Jude HPV Cancer Prevention Program. So in the first virtual seminar today, we'll focus on putting HPV vaccination data to work. How can we use these data sources to act and improve HPV vaccination coverage? This will include an overview of the National Immunization Survey Teen, or NIS-Teen Data from Cassandra Pingali with the CDC, an overview of program effectiveness reports from Alaya Koneru, also with the CDC, and then application at the state level with Alaya Kreft from the Nebraska Department of Health and Human Services. Before we begin today, I want to address a few housekeeping issues. Today's seminar will be recorded, and the link to view the recording as well as a PDF of today's slides will be shared with all who have registered. In addition, the recording link will be posted publicly in the future. If you have any issues during today's seminar, please use the chat. All participants are muted by the host. We will use the Q&A option for asking questions. You can post these questions at any time to engage with presenters and organizers. We also will use Mentimeter for you to join us in these conversations. We also are pleased to offer continuing education units for this activity. Please note that no one with the ability to control content for this activity has a relevant financial relationship with an ineligible company. And in order to receive credit, participants must attend the whole seminar today and complete this online survey. And the link to access this survey will be put in the chat as well. The purpose of our seminar series is to help you build your skills and enhance the capacity of your teams to improve HPV vaccination coverage. We know that many state-level teams have been focused on COVID-19 efforts or have been unable to return to a focus on HPV vaccination. The pandemic has disrupted HPV vaccination with more than 3.5 million doses and possibly more missed since March 2020. So now is the time for us to come together and recommit to addressing these important coverage gaps, which remain significant. So we hope these seminars may serve as a catalyst to help support these efforts across states. We've developed some specific learning objectives for today's seminar, and those learning objectives are listed here on the slide. What we hope to do is give you some behind-the-scenes looks at various data sources, but importantly, point to action. So next, we want to try out a Mentimeter question together. So Duha will put the information on how to join in the chat. You also can join by hovering your phone camera over the QR code that is displayed on the screen or texting the code, entering the code into menti.com to be able to join us with our first Mentimeter question. We would like to know from all of you, which state are you joining us from? So if you would take a moment to respond, let's see where folks are coming from. And the size of the state name indicates the most attendees. We have right now at this moment close to 150 attendees. Also feel free to throw it in the chat. We see New Mexico, Alaska, Alabama, New York, North Carolina, Texas, lots of different states coming through. Rhode Island, Ohio, Illinois, now they're really coming in through the chat. So this is wonderful. We have folks from all over the country, including California, Tennessee, which I'm sitting in Memphis, Tennessee right now. So this is great. Please go ahead and continue to respond to this question or throw the state that you're joining us from today in the chat. So our next question is, we would like to know from you, what is one thing you hope to learn from today's seminar? What is something that maybe you've been struggling with that would really help in your state catalyze efforts to improve HPV vaccination coverage? So let's see if we can move on to this next slide. How to take action. Thinking about that is a prime purpose for our particular seminar series, is how can we give you ideas for action? Helping parents understand the importance of HPV vaccine, getting health systems engaged, visual HPV data, how do we show that in a way that can be compelling? It looks like engagement with healthcare providers and others. So a lot are coming in, ways to bridge in gaps that exist in understanding. There's also some additional comments that I can see on my end. I'm sorry, I'm not sure why it's not scrolling at this moment. I'll take a look into that. But also a focus on rural, helping get kids back in for a second dose. Definitely a number of different ways in which we can address some of these ideas here in our seminar. So this is excellent. We hope to be able to provide you some insight here in our first of 3 seminars focused on how to help you get back on track with HPV vaccination coverage. And today we're going to be focusing on putting these data to work. So I'm going to switch over right now. You can continue to answer these questions. What we'll do is summarize these and share them with all who are attending the seminar series to have this information back too. So now it's really my pleasure to introduce Sandy Pingali. So Sandy is an epidemiologist at the CDC in the Immunization Services Division, and as part of her role as the subject matter expert, for the National Immunization Survey Teen, she leads a yearly MMWR assessing vaccination coverage among adolescents aged 13 to 17 years. And her research interests include adolescent vaccinations, vaccine confidence, and health disparities. So we are delighted to have Sandy. We all are anxiously awaiting to hear about this year's NIS-Teen Data report from you. And so let me turn things over to you. Thank you.
Hi, everyone. My name is Sandy Pingali, and I'm an epidemiologist at the CDC in the Immunization Services Division. And as Dr. Brandt said, I am the subject matter expert for the National Immunization Survey Team. And I'm very happy to be here today to give a national overview of HPV vaccination coverage and present the results from the 2021 National Immunization Survey Team. And this report was published in CDC's Morbidity and Mortality Weekly Report on September 2nd. Next slide, please. So I think first we're doing a question, and it's, does your state and or local health department publish vaccination coverage estimates online or in a report?
Sandy, we're seeing a few responses come through to say yes. A couple don't knows coming through in the chat. I'm not sure if anyone has logged in to the Mentimeter yet, but we're seeing some yeses and don't knows so far.
Well, my team is always very interested in states that do publish their estimates online or maybe have a report. Every year at the end of the MMWR season, we publish a report called the Total Survey Error Report. And we're always on the lookout for other data sources with which to compare the NIS-Teen surveys. So I'd love to hear the names of some of the states that do have these sorts of, coverage assessments, either online or in some sort of published report. Looks like quite a few yeses. So for my presentation today, first I'll introduce what the NIS-Teen is and the survey methodology. And then I will present some key findings from the 2021 NIS-Teen MMWR. And finally, we'll discuss an analysis in the MMWR, which examined the impact of the COVID-19 pandemic on routine vaccination. Next slide, please. So the purpose of the NIS family of surveys is to provide national and state level vaccination estimates that are comparable across geographic areas and time. And it can be used to assess health equity and engage community partnership to promote vaccination. It's also a flexible tool which can be used in public health emergencies, such as the addition of the COVID modules, to collect COVID vaccination data and intent on age-eligible children and adults. And that's the NIS-CCM and NIS-ACM. But the presentation today will focus on the NIS-Teen, which obtains information from parents of adolescents ages 13 to 17 years. Next slide, please. So the NIS-Teen survey consists of two phases. So the first phase is a random digit dialed telephone survey of households with teens. And then the second phase is a mailed survey of vaccination providers. So the household survey collects sociodemographic information and requests permission from the parent to contact the teen's vaccination provider. And then if permission is granted, then a mailed survey is sent to all vaccination providers identified by the parent. And then for the provider survey, this collects data on when vaccinations were received, which types of vaccinations were given, and how many doses the teen has had. So at 11 to 12 years, adolescents are routinely recommended to receive meningococcal vaccine, human papilloma vaccine, and then tetanus, diphtheria, and whooping cough vaccine. And so teens are classified as being up to date based on the ACIP recommended number of doses for each vaccine. So the 2021 NIS-Teen included 18,002 teens who were born between January 2003 and January 2009. Next slide, please. So now we'll review some of the key findings from the 2021 NIS-Teen survey. Next slide, please. So this slide shows the trend in vaccination coverage from 2006 through 2021 for adolescents 13 to 17 years of age. And coverage with Tdap vaccination is shown in red, and then meningococcal vaccination is shown there in the dark blue. HPV vaccination initiation is shown in orange, and percent HPV up to date is shown in green. And then additionally, the second dose of MenACWY is shown in purple, and the first dose of meningococcal B is shown in light blue. And so nationally, vaccination coverage for Tdap and MenACWY has been high and stable at about 90%. And then coverage for the first dose of HPV vaccine is at about 77%, and percent HPV up to date was about 62% in the 2021 survey. And although coverage for the HPV vaccine measures is lower than for other vaccines, coverage for one or more doses of HPV vaccine significantly increased in 2021 by 1.8 percentage points, and then HPV up to date increased by 3.1 percentage points. So in 2013, NIS-Teen implemented a revised adequate provider data definition, and then retrospectively applied this definition to the 2013 data. And so this is shown by the break in the lines there at 2013. So under the revised definition, to have adequate provider data, teens must have vaccination history from one or more named vaccination providers, or the parent reported that the teen was completely unvaccinated. And then in 2018, NIS-Teen changed from a dual cell phone and landline sampling frame to just a single cell phone sampling frame. And so this is shown here on the graph at 2018 with the vertical line. And then in 2021, this year, we updated the adequate provider data definition again to specify that teens must have vaccination history from one or more non-COVID vaccination providers. And this was because some teens only had vaccination history reported from a COVID vaccination provider, but then they didn't have any data on routine vaccinations. So next slide, please. So shown here is HPV vaccination initiation by state, and there is wide variation in coverage across the country, ranging from 56.2% in Mississippi to 90.1% in Rhode Island. And coverage is generally lower in the Southeast, and then higher in New England and North and South Dakota. Next slide, please. And then in this slide, this is showing percent of teens HPV up to date by state, and coverage ranges from 32.7% in Mississippi to 83.2% in Rhode Island. And you can see a similar coverage pattern here for HPV up to date as we saw with HPV vaccination initiation. Next slide, please. So we also see differences in HPV vaccination coverage by urbanicity, and HPV vaccination coverage has been consistently lower for adolescents living in rural areas, noted here in red, than adolescents living in urban areas, noted in blue. So this difference in coverage by urbanicity does appear to be narrowing with the most recent years of data. And as a positive note, vaccination coverage has been increasing for rural adolescents at the same rate that it's been increasing for urban adolescents. Next slide, please. And we also see coverage differences by health insurance status. So teens with any Medicaid insurance have higher coverage with one or more doses of HPV vaccine compared to teens with private insurance. And this may be due to access to the VFC program for teens with Medicaid insurance. And then uninsured teens had lower coverage for both one or more doses of HPV vaccine and HPV up to date compared to privately insured teens. Next slide, please. Vaccination coverage by poverty status also shows an interesting pattern for teens living below the poverty level. Teens living at or above poverty level were the reference group here. And HPV initiation and the percent of teens HPV up to date is higher for teens living below poverty level compared to at or above poverty level. And again, we think this might be due to access to the VFC program for teens living below the poverty level. Next slide, please. So more information on adolescent vaccination coverage data can be found on CDC's Teen VaxView website in the Teen VaxView interactive section. And you can also view publications and reports and learn more about the Healthy People 2030 objectives here. Next slide, please. So next, we'll discuss an analysis we did to assess the impact of the COVID-19 pandemic on routine vaccinations among adolescents. So in contrast to other vaccination data reports, the NIS-Teen survey data have shown that HPV vaccination coverage has been increasing each year, even during the pandemic. So in 2020, we reported that HPV vaccination initiation increased 3.6 percentage points, and the percent HPV up to date increased 4.4 percentage points. And then in 2021, the increases were smaller at 1.8 percentage points for HPV vaccination initiation and 3.1 percentage points for percent HPV up to date. But it's important to note that the 2020 NIS-Teen was limited in its ability to evaluate the pandemic effects, since most of the teens included in the survey that year had already started HPV vaccination before the pandemic was ever declared. And so it wasn't until 2021 that the NIS-Teen survey included age-eligible teens that were due to receive routine vaccinations during the pandemic. And if you remember from my earlier slide, this is because routine vaccines for adolescents are recommended at ages 11 to 12 years, while the NIS-Teen survey includes adolescents ages 13 to 17 years. So the 2021 survey is the first year to include adolescents who reached age 12 during the pandemic in 2020, and now they've aged into the NIS-Teen sample at age 13 in 2021. Next slide, please. So our analysis consisted of assessing vaccination coverage by age milestone and year of birth. And in order to have adequate sample size for each birth cohort, we combined data from the 2015 through the 2021 NIS-Teen surveys. And then we also used Kaplan-Meier estimation to account for the censoring of vaccination status at ages 14 years and older. So to assess impact, we compared the vaccination coverage of the birth cohort reaching a milestone age during the pandemic to the vaccination coverage of the birth cohort reaching the milestone age before the pandemic. So next slide, please. So in the next series of slides, I'll show some tables with vaccination coverage estimates by birth year and milestone age. And in each table, the cohort reaching the milestone age during the pandemic is highlighted in yellow, and then the cohort reaching the milestone age before the pandemic is highlighted in orange, as you see on the screen. So in my example shown here, using the milestone age of 12 years, we would be comparing the vaccination coverage estimates of the 2008 birth cohort who reached age 12 during the pandemic to the 2007 birth cohort who reached age 12 before the pandemic, and to see if there was any change in coverage. Next slide, please. So now let's look at the results for the first dose of HPV vaccine. And again, the birth cohort reaching the milestone age during the pandemic is highlighted in yellow, and the birth cohort reaching the milestone age before the pandemic is highlighted in orange. And so we compared the vaccination initiation coverage during the pandemic to the most recent pre-pandemic baseline shown here on a diagonal in orange. And so the results for the milestone age of 12 years are outlined here by this red box. And here you can see that vaccination coverage among the 2008 birth cohort is similar to the coverage estimate for the 2007 birth cohort. So at this point, we are not yet seeing a negative impact on HPV initiation during the pandemic. Next slide, please. So now let's focus on the milestone age of 13 years. So note here, we now have 2 birth cohorts who reached the milestone age during the pandemic. So first, let's focus on the youngest birth cohort, the 2008 birth cohort in red. And again, we see that the estimate for the 2008 birth cohort is similar to the estimate for the 2006 birth cohort, indicating no impact of the pandemic on HPV vaccination initiation in the 2021 data. Next slide, please. So now we're going to look at the 2007 birth cohort, and we see that the estimates are slightly higher than in the 2006 birth cohort, but the estimates were not statistically different. And then if you were to look at the other milestone ages, so by 14 years, 15, 16, the estimates were not statistically different, and this pattern continues up the diagonal there. So at this time, we are not seeing a decrease in HPV vaccination initiation coverage during the pandemic. Next slide, please. However, we are seeing a different pattern for meningococcal vaccination. So Looking here at the milestone age of 13 years, we see that coverage for the 2008 birth cohort is 5.1 percentage points lower than for the 2006 birth cohort. So here we are starting to see some impact of the pandemic on meningococcal vaccination. Next slide, please. And we're also seeing a negative impact of the pandemic on Tdap vaccination. So at age 12, shown here in the red box, we see that the coverage estimate for the 2008 birth cohort is 4.1 percentage points lower than the estimate for the 2007 birth cohort. And then if we looked at the age 13 milestone, the coverage estimate for the 2008 birth cohort is not significantly different than the pre-pandemic coverage in the 2006 birth cohort, but it was 3.1 percentage points lower. It just wasn't statistically significant. Next slide, please. So these graphs are a visual representation of the tables that I just showed. And the dark blue line represents the 2008 birth cohort. So this is the youngest birth cohort in the 2021 data. And you can see here in the bottom graph for Tdap and then in the top right for men ACWY that this dark blue line is lower than previous birth cohorts for the coverage. However, if we look at the top left graph for the HPV graph, here the 2008 birth cohort is not significantly different from the other birth cohorts. Next slide, please. So in summary, in the 2021 NIS-Teen results, we showed that HPV vaccination coverage continues to increase among teens 13 to 17 years, although it is still lower than other routinely recommended vaccines. And we continue to see differences in coverage by sociodemographic factors. And while we are not yet seeing any impacts of the COVID-19 pandemic on HPV vaccination, we are starting to see a drop in coverage for younger birth cohorts for Tdap and meningococcal vaccines. And it's not yet clear why the impact was not similar for all vaccines. But we will continue to monitor the impact of the COVID-19 pandemic, and we should be in a better position to do this as children who were ages 11 and 12 when the pandemic was declared age into future NIS-Teen samples. Next slide, please. So thank you for having me here today, and I look forward to the Q&A session at the end of the webinar. And if you have any questions about the information in this presentation, please feel free to reach out to me at my email address.
Thank you so much, Sandy. And we do have a few questions in the Q&A if you are interested in responding to those. And just as a reminder, please do post your questions in the Q&A, and that way we'll be able to allow our presenters to engage with you during this process and also hit some of these questions that are ripe for discussion a little bit later. So our next presenter is Alaya Koneru, who is a health scientist and epidemiologist at the Immunization Services Division at the CDC. Her work focuses on routine immunization activities for children and adults, and she co-leads CDC's program effectiveness, which aims to achieve high vaccination coverage across populations. She completed her MPH and undergraduate studies at the University of Alabama at Birmingham. So welcome, Alaya.
Thank you. Good afternoon, everyone. Like Heather stated, my name is Alaya Koneru, and I co-lead the program effectiveness work based out of the Immunization Services Division at CDC. Next slide, please. I'll start by giving some context to these reports with an overview of program effectiveness, or P, as you'll hear me saying. And then I'll share some national data compiled from these reports and also show an example of what these reports actually look like at the state level. And finally, I'll share some potential action steps for these reports and provide some additional CDC resources. Next slide, please. So we're curious to know if you've seen one or more of the program effectiveness non-flu VSC doses ordered via CDC's VTRCKS reports. And it looks like a good number of you have, which is really great to hear. Next slide, please. So what is program effectiveness, or PE? PE is a component of CDC's Immunization and Vaccines for Children, or VSC Cooperative Agreement, which gives funding to 64 awardees to conduct immunization activities. The overarching goal of PE is to ensure high vaccination coverage across the population and within population subgroups. And this can include adults, children, adolescents, or even more specific populations within those groups. The basic requirements of PE include identifying populations with low vaccination coverage and selecting at least one population for a targeted activity to improve vaccination coverage. For example, a state might have reviewed Sandy's NIS-Teen Data and identified that adolescent HPV vaccination coverage rates are low in their state. They might choose to do a county-level assessment to identify counties with high HPV coverage and best practices, and then roll out a pilot program implementing best practices in lower coverage counties. Next slide, please. We know that the COVID-19 pandemic has impacted and continues to impact routine medical care for many, including for immunizations. For children and adolescents specifically, a 2020 MMWR demonstrated a substantial decrease in pediatric vaccine doses ordered and administered at the beginning of the pandemic. Program effectiveness, with its focus on identifying and addressing populations with low vaccination coverage, can help address decreased routine childhood immunizations and other areas where coverage is potentially lacking. Next slide, please. During 2020, we temporarily paused required activities for PE as awarded resources were diverted to the COVID-19 response. Routine immunization still remain and continues to remain a high priority, and children falling behind on vaccinations were and continue to be a concern. We knew that awardee resources were stretched thin, so we thought we could assist by producing awardee-specific county-level VSC ordering reports that could potentially help in focusing efforts. Next slide, please. These awardee-specific reports contain non-influenza VSC doses ordered through CDC's Vaccine Tracking System, or VTRCKS. As the title indicates, these reports include vaccine ordering data for doses ordered through the VSC program. These reports have been shared with awardees since 2020. The newest version of these reports, which will actually be shared later this week, contain ordering data assessed at the state and/or county level by all doses ordered or by antigen doses ordered, and by the most recent data update or cumulatively throughout the pandemic. Next slide, please. I included this slide for reference, and I'm going to skip down to the last bullet. In the 2021 and 2022 reports, we used two definitions throughout our report. The pandemic period, which for the purpose of this report, we're going to define as January 2020 through the most recent data update included in that report. And the base period, which is the average of 2017 to 2019 months that correspond to the number of months included in the pandemic period. Next slide, please. Next slide. In the next few slides, I will go over some national ordering data before discussing an example of a state-level report. These figures include our most recent data, which goes through June of 2020. This national map shows the cumulative changes in all non-flu VSC doses ordered during the entire pandemic period compared with pre-pandemic. The majority of states had decreased ordering during the pandemic. 26 states had a decrease in ordering of about 10 to 30%, and this is shown in orange, and 24 states had a less than 10% decrease, shown in dark gray. 2 states actually ordered an increased number of vaccine doses during this time. Virginia, which is shown in light gray, had an increase in orders of less than 10%, and Rhode Island, which is shown in green, had an increase of 10 to 30%. Next slide, please. This national map shows cumulative changes in ordering comparing the pandemic period to pre-pandemic, but this map actually focuses only on HPV vaccine doses ordered through the VFD program. Overall, ordering for HPV vaccine doses decreased in most states. 3 states had a decrease in orders of greater than 30%, and this is shown in red. 37 states with a decrease of 10 to 30% are shown in orange, and 11 states are shown in gray with a decrease of under 10%. Next slide. The next several slides will focus on the state level PE reports, and I'll be using the report for Alabama as an example. Each report contains a cover letter, which you can see on the right, and this cover letter contains an overview of the data included, recommendations for sharing the report both internally and with partners, and also a list of additional CDC resources. Next slide. The first figure in the state level reports is a county level map of ordering changes cumulatively over the pandemic compared to pre-pandemic. The red and orange colors on this map represent decreases of greater than 30% and 10 to 30% respectively. The white shows a less than 10% change in ordering, which can be either an increase or decrease in ordering. And the light green and the dark green represent increases in ordering of 10 to 30% and greater than 30% respectively. And also the diagonal lines over a county indicate that it is a rural county. I'm going to use Bibb County as an example over the next few slides. Bibb County is located in the center of the map, slightly to the left. I know this is a little challenging to see on the slide, but Bibb County is an urban county highlighted in white, and their orders decreased about 7% over the pandemic compared to pre-pandemic. Next slide, please. So figure 2 in the reports also show recent changes in ordering at the county level. The information presented in this table is very similar to the map in the previous slide. However, this table focuses only on ordering data for a short time frame, which is January through June of this year. I'd like to also highlight that the tables contain subtotals for urban and rural counties, which for Alabama shows a 3% decrease and a 3% increase in ordering respectively, and a grand total for Alabama and a U.S. grand total as well. Again, using the example of Bibb County, if you find it in the first column, I believe it's the 4th one down, we know from this table that Bibb County is an urban county, and they ordered an average of 1,662 doses in January through June pre-pandemic, and this is in the blue text. And during January through June of this year, 2022, they ordered 1,993 doses, which is an increase of 20% for this year alone. So going back to the data in figure 1, we know that Bibb County has had a cumulative decrease in ordering overall during the pandemic of 7%, but this year, based on this data alone, it looks like things are picking back up and they're now in the green. Next slide, please. Figure 3 is also a table of ordering at the county level, but this figure breaks out ordering by month. Using Bibb County again, we know that they are an urban county, and in 2021, they ordered a total of 3,250 vaccine doses, which you can see in the green text. On the right side of the table, the doses ordered for 2022 so far are shown by month. You can see for January, 595 doses were ordered, and for June, 605 doses were ordered. So in summary, figures 1 through 3 in the PE reports show county-level non-flu VXC vaccine doses ordered, and data are assessed in different ways, either cumulatively over the pandemic, more recently just for 2022, and by month for 2022. Next slide, please. The next two figures in the report focus on non-flu VFC antigen doses ordered, where the previous figures focused on vaccine doses ordered. This is not a complete list of antigen groups included in VFC vaccines, but we chose to include these specific antigens to represent different age groups across pediatric populations. Let's look at HPV doses ordered, which are the third set of bars from the left in the center of your screen. The dark blue bars show average number of doses ordered for January through June pre-pandemic, and the light blue represents January through June doses ordered for 2022. And we have both national and state level data in here. So nationally, about 1.7 million HPV doses were ordered pre-pandemic over January through June, and 1.5 million doses were ordered for 2022 for that same time period, January through June. This is about an 11% drop in ordering, which is shown in the blue box at the bottom of the figure, and a 10% and 13% drop for urban and rural counties respectively. And this is shown in the orange and green boxes at the bottom of the figure as well. For Alabama specifically, 27,000 HPV doses were ordered pre-pandemic, and about 26,000 doses were ordered for 2022 so far. This is about a 6% decrease in ordering overall, and a 6% and 7% drop for urban and rural counties. Next slide, please. Figure 5 in the report is actually multi-part and covers each of the antigen groups listed on the previous slide. However, I'm going to focus only on the HPV data. This cumulative line graph on this slide shows VFC HPV doses ordered by month from January 2020 through June 2022. The blue line represents the average monthly doses pre-pandemic, and the dotted purple line shows monthly doses ordered over 2020 through 2022. Both of these lines correspond to the left axis. The dotted red line shows the cumulative difference in ordering between the pandemic and pre-pandemic time periods, and this line corresponds to the axis on the right. If you look to the very end of the graph for 2022, you'll see that HPV ordering for June 2022, and again, that's the purple line, slightly exceeds monthly orders for June pre-pandemic, and this is the blue line. However, if you look at the red cumulative line, you'll note that overall, for the entire pandemic period, HPV ordering has decreased by about 11,000 doses for Alabama, or a 7% decrease, and this information is highlighted in the top right-hand box in red. Next slide, please. I want to briefly discuss some limitations using the non-flu VFC ordering data shown on the previous slides. Ordering data is used here as a proxy for coverage. However, changes in the number of doses ordered do not necessarily reflect changes in vaccine doses administered. And these reports only include publicly purchased VFC vaccine doses and do not include private doses. Additionally, these reports do not directly account for fluctuations in the number of children eligible for VFC, so it's important to keep for context. And the most recent VTRCKS data available are used to create each report and might not reflect post-extraction changes to the data, such as changes in orders and data entry errors. Next slide, please. Next slide. So in summary, the PE non-flu VFC vaccine doses ordered via CDC's VTRCKS system reports are awardee specific and include county level data. These reports are shared with PE points of contact at immunization programs periodically throughout the year. The purpose of these reports is to aid awardees in ensuring that children continue to get caught up quickly on their routine vaccinations. I want to emphasize that these reports are a single tool that should be used in conjunction with other data sources and institutional knowledge. You all are the experts in what is happening in your states, so please use these tools as a part of your toolkit. These reports can help you prioritize your immunization efforts and quickly identify geographic areas and/or vaccination programs with potentially low coverage rates. Next slide, please. So some action steps for stakeholders. CDC strongly recommends that immunization programs use your reports for guided outreach to the community, local public health, specific providers, et cetera, as appropriate. We also encourage that you share these reports widely, such as with your local health departments, VSC providers, your immunization coalitions, your local AAP chapter, and your schools and your Department of Education. If you are an immunization program partner, and if you would like to see your state's reports, please reach out to your state immunization program. And if you have feedback on the content of these reports and might want to see, more data added or less, or any feedback that you have, please reach out to the CDC PE team at the email listed on the slide. Next slide, please. I also want to share with you some additional CDC resources. CDC's VaxView, which contains dashboards of vaccination coverage data for all ages. And then there are some resources to encourage routine childhood vaccination, including a childhood vaccination communication toolkit for clinicians. There is also a CDC expert commentary that's linked on here as well on adding routine and COVID-19 vaccination to the back to school checklist. And last but not least, CDC has an awardee level VTRCKS historical ordering tool, or VHOT, which was designed to help identify changes in VTRCKS doses ordered. This is it's a very comprehensive tool including all the data, ordering data included in VTRCKS, not just limited to VFC. It's an Excel format and it's very dynamic, and you can pull out pieces of information that may be most helpful to your work. I believe these tools are now available only by request. So if you want access to this tool, please reach out to Kevin Gibson at the email listed on the slide, and he can provide you with information, access, and potentially also training for the tool. And next slide, please. I'd like to acknowledge the folks listed on the slide, particularly Alabama, the Department of Public Health there, for allowing me to use their reports in this presentation. Thank you.
Thank you so much, Alaya. Really appreciate that very thorough presentation. It was a great presentation, and I've already seen some questions come through that are going to be great for our discussion. So now I want to transition to our third and final presenter for today, and that's Alaya Kreft. So Alaya's been with the Nebraska Department of Health and Human Services Immunization Program as a community health nurse for the past 3 years. She serves as the vaccine safety coordinator as well as the program's education and quality improvement coordinator. Alaya attended nursing school at Southeast Community College and graduated in 2009 as a licensed practical nurse, and in 2013 with an associate degree in nursing. She has work experience in long-term care, med-surg, infusion, and case management. She intends on pursuing her master's degree in nursing to become an educator, as her passion lies in teaching others. So Alaya, I'm going to turn the presentation over to you.
Thank you very much. Like she said, my name is Alaya. I'm a community health nurse for the state of Nebraska. And so I think we will just go ahead and get started. Next slide, please. So we'll start off here with another poll question. What percentage of teens, boys and girls, were fully vaccinated against HPV in the United States in 2021? Actually, this was covered by Sandy and our first presenter, so hopefully maybe some of you can remember. So actually, nationally, fully vaccinated against HPV teens were about at 59%. So while we would like it to be a little bit higher, something that we need to work on. So this next slide is currently where Nebraska is. So we are sitting previously we had been sitting just above the national average. When I was first asked to do this presentation, they asked why, how did you get there? And we really couldn't pinpoint a specific reasons as to how or why we got there, just that we are. So the this picture to the right shows the United States as a whole and their average. And again, I realize this is a duplicate picture from Sandy's presentation earlier, but I just kind of wanted to give everybody a good look at, just where all of the states are in comparison to Nebraska. Next slide, please. So how we got there. Currently, can you go back to the previous slide? Perfect, thank you. Currently, the Nebraska State Immunization Information System, or NIS, as what we call it, it shows that HPV vaccination can be administered as early as 9. That piece of information was implemented into the IIS in 2010. Currently, right now, we have 3,063 organizations registered into using NIS. Those could be healthcare providers, school nurses. They have access to view immunization records for students, although they don't have access to enter those immunizations into the system. Currently, right now, Nebraska does not have mandatory vaccination reporting. So right now, it's only as good as we can get the providers to use it, but there are quite a few providers in Nebraska that do utilize this. We currently have 290 healthcare providers currently enrolled in the Nebraska VFC program. Out of those 290, 25 of them have subawards. And out of those 25 subawardees, 19 of them have HPV focus objectives. So our subawards, there are certain criteria that they have to meet, basically stating how they are going to increase on-time vaccinations. Some of those plans include marketing, hosting vaccination outreach clinics at schools and county fairs and things of that nature. One of the nice things I feel like that has helped our subawardees is that they were allowed to keep the same work plans for the fiscal years of 2020 into 2021 and 21 into 2022 due to COVID, which allowed them to maintain the momentum they had been making with efforts and plans they already had in place. Recently, Nebraska has been able to resume IQIP efforts with our VFC providers. So basically, IQIP is the immunization quality improvement for providers that focuses on assisting providers with resources to improve on-time immunizations rather than catch-up immunizations. It's our quality improvement plans. And one of those core strategies that IQIP focuses on is giving a strong vaccine recommendation. So from the immunization program, our role is to provide resources or technical assistance, as they like to put it. We give that to providers to support conversations of strong vaccine recommendations. Typically, those resources are HPV focused, but they do include all vaccinations recommended for, in this case, ages 12 to 13. Nebraska also requires mandatory vaccination for school enrollment for children entering kindergarten, 7th grade, and all out-of-state students entering the school system. While the HPV vaccine is not included as a mandatory vaccination, Tdap is mandatory. So the strong recommendations kind of plays into bundling the Tdap, the HPV, and the meningococcal vaccinations together. Thus, it initiates the HPV series. So we found that a lot of our kids have gotten that first dose of HPV vaccine. It's that second one that they're lacking because along with mandatory vaccinations, Nebraska also requires that you have a physical when entering the 7th grade level. So, you know, if kids aren't playing sports, sometimes they don't go back to that doctor the next year. And I think that kind of plays into the part where that second HPV vaccination gets missed. Next slide, please. So this is what our IIS looks like when you pull up a patient of this age. I just want to give a little disclaimer. This is a test patient. Can you go back, please? Thank you. This is a test patient, so it's not actually a patient record, and it was done in the testing environment as well. But if you notice, the date of birth would be 2013. So down towards the bottom, it gives the recommended HPV. The recommended date for HPV would be August of 2024, but the earliest date it can be given shows August 15th of 2022. So that is right there for our providers to see. And that way that gives them, you know, either they promote that vaccine that day, or they can start having those early conversations with parents and guardians. Next slide, please. All right, what can be done? So from the state level, really from any level, whether it's state, provider, or even parents, identifying barriers to that HPV vaccination. Currently, the ACIP still recommends that it begins at age 11, but there's but it can be given as early as age 9. And I really think that promoting the messaging that it can be given as early instead of saying it's recommended for age 11 to 12, just kind of changing the verbiage of that can help promote starting that vaccination series at age 9. Resuming normal practices and reevaluating what normal is after COVID. I understand that some practices are still very bogged down with high staff turnover rates, burnout, there's staffing shortages. Some practices, patients still aren't coming in like they were prior to COVID, and it's really just going to be just kind of taking that leap and getting things back to normal, or whatever that normal is going to look like. Increasing support for partners and providers, such as messaging, educational opportunities, and technical support, really just kind of being that crutch for providers to lean on and ask questions and get information for. And then collaborating with the IIS to enhance patient and provider operations. I know we, as the immunization program here in Nebraska, work rather closely with our IIS partners, trying to figure out what you know, the ins and outs of the IIS, how it works, what can be done, how do we make this better type of things. From a provider level, again, identifying those potential barriers based on patient populations, beliefs, previous encounters. You know, have you had pushback with HPV vaccinations? What those conversations look like? You know, your patient population, any religious beliefs that would play into all of those things. I previously worked at a doctor's office where we only provided vaccines to children during child visits. I realize that sometimes that's a barrier from the insurance company, but not all. So really taking a good look into that and figuring out if you can immunize your patients when they come in if they are not acutely ill. Making small changes to your workflows can really have big results, and they're much easier to manage. So I highly encourage when you take this back to your practice and say, how can we make this work? It's those small changes that are really going to make the biggest impact on what you're doing. And it's going to be easier for your staff to manage and be on board with those changes. Providing a safe and comfortable environment for parents and patients to ask questions. This is huge. If you, as a provider, it's extremely important to decide or acknowledge your thoughts on vaccinations before you discuss that with your patients, and giving them an open and comfortable environment to talk about things, ask questions. I have 3 kids of my own. I've been in doctor's offices where there was no, and I'm a nurse, so I know enough, but I still have questions, and those environments didn't make me feel comfortable to ask questions. So that's extremely important as a parent, is to be able to feel comfortable asking questions and not feeling like you're insignificant or dumb, for a lack of a better word. And then really just promoting that HPV vaccination as cancer prevention. Straightforward. That's what it is. If you can help prevent your child from getting cancer, wouldn't you want to do that? And as myself, I'm a parent, and I'm sure there are several others of you that are, but becoming familiar with vaccine recommendations. As a parent, I would suggest knowing what you're walking into if you go into the doctor's office, or knowing, hey, my child's 9. I think I heard that they could get that shot right now. I should probably call the doctors. Just knowing the information that's out there and what you can do to help protect your child. Talking with your health.
Allie, just another minute or so.
Yep, I'm just about done here. And then asking questions. Keeping scheduled appointments and not delaying those appointments is really important too. And then my next slide. So my takeaways for this are identifying barriers to HPV vaccine administration, cultivating an understanding and comfortable environment for parents, should be presented as cancer prevention, and small changes can have a big result. Last slide. So our Nebraska slogan is, honestly, it's not for everyone, but luckily vaccinations are.
What a great way to conclude, Allie. Thank you. I really like this slide a lot. All right. Well, thank you so much, Allie, and thank you to Alaya and Sandy as well. I'm going to do just a very quick summary so we can jump into discussion. And remember, if you have questions, please use the Q&A function. That really helps us tease out those questions rather than going through the chat. So just a few observations. I think as we were exploring putting HPV vaccination to work today to improve those data, to improve our use of data to inform our action, I think we learned from the NIS-Teen data that we continue to see overall positive trends. There certainly are differences and disparities among certain population groups that require our attention. And it seems like we need to continue to monitor as a result of the pandemic. There seems to be not as much of an impact as an HPV as compared to other routinely recommended vaccinations for a similar age group. However, I think even Sandy would say we should continue to monitor this because we're still early in this opportunity to examine those effects. And in terms of these program effectiveness reports, what a useful tool to help us really monitor HPV vaccination within our states and partner with state level organizations who are using these particular reports. And we just heard from Allie in Nebraska about a way in which they've been using their state immunization information system to facilitate that earliest date starting HPV vaccination at age 9, and also some really solid recommendations for ways in which these data are highly actionable on a state level. So now I want to transition to a discussion with our presenters for today. And this will be the question and answer portion. So please make sure to type in questions if you have them. We have a few questions just to get us started today. So Alaya, Allie, and Sandy, if you guys would come back on, turn on your cameras and unmute, we'll get started with some of these first questions. So Sandy, I first want to start with you. So based on the NIS-Teen Data, what steps should healthcare providers and public health officials take to really get us to that Healthy People 2030 goal of 80% vaccination coverage? Let me unmute you.
Got it.
Okay.
I think the most important thing that parents and providers and public health professionals can do is really to get out the message that we need to make sure that adolescents, children, anyone who is due for a routine vaccination during the pandemic, check their vaccination record. Parent can check it, the provider can check it. Just really make sure that we are checking these vaccination records and keeping children and teens up to date on the routinely recommended vaccines.
Thank you. And Alaya, how can organizations use these state level data reports to implement programs to increase HPV vaccination?
Yeah, so the beauty of these reports is that it is sort of a static PDF report that you can hand out to your partners, both within your health department and externally. So I think this is a really good, the reports can serve as a starting point to initiate those conversations and engage with partners.
Thank you. And Allie, you mentioned in Nebraska, you guys in your IIS include that nice screenshot you shared with us, that earliest start date is at age 9 for HPV vaccination. What other states are using a similar approach that you may be aware of?
No, unfortunately, I can't. I was not able to find that exact information. I do know that we share the same IIS platform with about, I want to say 17 other states. So there's a good possibility that there are at least, I'd say probably 17 of those other states that potentially are following the same guidelines.
Thanks. And a couple of people put in the chat that Arizona is doing this, Virginia is doing this, and there's a plan in Utah for them to do this as well. So those are some of the states. And Allie, I'm going to come right back to you here. What barriers are you aware of that healthcare providers have been facing on sort of a county level in Nebraska in terms of improving HPV vaccination?
So we just began the IQIP process, as I briefly explained earlier, and the providers that we have visited and discussed with, because part of that is focusing on HPV vaccination, it's parents. Either A, they're not sure, or early introduction of HPV seemed to focus that it was a sexually transmitted infection, and parents are under the impression that if they vaccinate their children with HPV vaccine, that this gives them the green light to be sexually active. And I think there's a lot of stigma around that particular piece right there, which is why we're trying to change the focus on, or trying to change the narrative that HPV is cancer prevention.
Thank you. And it sounds like, I mean, you had several recommendations as well, for healthcare providers, things they could do, and most importantly, promoting it and talking about it as a primary strategy and framing it in that way. So Alaya, what are some of the best practices that can be used to access these really great reports by immunization program managers?
Yeah, so if you are a PE contact, you may or may not be an immunization program manager. So if you work in the health department, you can reach out directly to your PE staff in your health department. And or if you need help connecting with them, you can reach out to the PE mailbox and we can help you connect there. If you are a partner and you're external to a state health department, it gets to be a little bit more tricky because these data are state data. And we have to be sensitive to that. So ultimately, it is up to the state health department about whether or not they want to externally share the reports. But I would say
Go ahead.
I was just going to add that it does seem, we've gotten some feedback that partners are getting those reports, so it seems like many health departments are willing to share and do share.
Thank you. That was another question that came through a private chat was, how do we access this report? Who is the best contact for us? Is it within our state? Is there a designated person? Do folks contact you? What is the best way if somebody's interested? What would you recommend?
Yeah, I would start with reaching out to your immunization program manager at your state health department. If you have trouble locating that person or they're unable to locate the PE's point of contact that I reach out to, you can reach out to our mailbox and we can do our best to put you in contact with those folks.
Great, thank you. So Sandy, I'm going to come back to you. One of the main reasons why our organizations and all of us have come together to offer this series is because of the effects of the pandemic on routinely recommended vaccinations for adolescents and trying to understand how we can support state-level teams in these efforts. You've been doing a great job in the chat and in the Q&A responding to people's very specific questions. I wanted to give you a chance to just share with everyone though, do we continue to monitor the effects of the pandemic? Do we already know the answer? And what are your thoughts about maybe why the VFC ordering data continue to show down 11% nationally, but we haven't yet seen the effects in NIS-Teen? Tell us a little bit about what you're thinking there.
So we definitely need to continue monitoring. Right now, we're only getting about half of the pictures. So this was the first year we had adolescents who were 12 in 2020 aging into the sample when they turned 13 in 2021. But we still need the adolescents who were 11 in 2020 aging into the sample. So we'll get those adolescents next year in the 2022 NIS-Teen survey. So I think, it's very important that we analyze our data with those adolescents included in the sample. And then I think for the VFC, the ordering data question, the direct relationship between VFC ordering data and how that translates into coverage is not very well understood. And it is something that the CDC is looking into. So there's colleagues of mine looking at selected IIS data and some other data sources to try and understand how does drops in ordering translate, does that translate to a drop in coverage? And it's just something, that relationship is just not super well understood at this time. And then if you look at our data, about half of the NIS-Teen sample is VFC eligible. So we're also looking at a mix of teens, who are VFC eligible and then not VFC eligible. So, I think some important points there to consider with the data.
Thank you. There are a few other questions that are coming through. I want to get to a couple of these to give you all a chance. One of the questions was about taking a look at race and ethnicity among the NIS-Teen data. Pre-pandemic, we saw actually coverage lower among white adolescents. What do those trends look like with this latest group of data?
Yes, so we did do this analysis by race ethnicity in the MMWR. And if you look in the footnotes of the MMWR, because we needed to devote so much space to the pandemic analysis this year, some of the things we usually report on, such as health insurance differences and race ethnicity differences, those are now in the footnotes, and there's a link to the results that you can pull up. And we did look at race ethnicity differences, and we still are seeing this pattern. It's usually what we find is Hispanics and Black adolescents have higher vaccination coverage than white adolescents for HPV vaccination. And we saw that again this year. I believe Hispanics were not significantly different from whites, and then Black adolescents were significantly higher than white adolescents for HPV vaccination this year.
Thank you. And a couple of other questions about, what if somebody, you guys may or may not have an answer to this, but if someone doesn't know if they've been vaccinated, of course, there's no harm in getting additional doses of HPV, but, being more cognizant of the fact that it is 2 or 3 doses depending on age, how could someone check?
So we actually recommend, we have a lot of those phone calls that come into our office, and the best way to do that is just to contact your primary care provider. Even if you do switch providers, usually when your records are transferred, if there is immunization records, those will be transferred as well. Checking into the IIS is always a good place to start as well.
Great, thank you. Well, I just want to thank all of you so much for this excellent information and for really kicking off our series in a powerful way with sharing all of these data. So for those of you who've joined us, please do take a moment to complete an evaluation of our seminar. The link is included in the chat, and I also am going to put it up here on the screen for you in case you want to grab the QR code. Thank you to everyone who's planned the seminar, our presenters, and our partners at the American Cancer Society National HPV Vaccination Roundtable and Indiana Immunization Coalition. And thanks to all of you, of course, for joining us. As a reminder, this seminar was recorded and a link will be available along with a PDF of the handouts from today's presentation. Please make sure to join us for our second and third seminars in this series. Our next one is coming up on October 18th. So we have the data. Now, how do we implement best practices to really act on that information? And then lastly, monitoring the process and impact of our efforts to do this work is coming on November 15th. So thank you again, everyone, for joining us. I'm sorry we didn't have a chance to get to everyone's questions, but I hope that you found value in today's seminar. So thank you again, everyone, and have a great day.